Welcome to DocTalk Live. I have roped Dr. Nicole Massie to sit with me today, and I appreciate you coming in. So people that are new to DocTalk Live, like yourself, I will give a chance to explain what this is about. So I would say 20 years ago I used to have a radio show, and I used to talk on the radio, and people would call in with questions, and it was every Saturday morning, and it was called DocTalk. And I've been trying to bring DocTalk back, but I didn't really know how to do it. And then, I discovered Facebook, and people were doing this Facebook Live stuff, and I'm like, oh, well, maybe we could do DocTalk Live on Facebook. And so I don't know if you scroll through Facebook at all, but you see pictures and videos and things like that. So right now we are on Facebook.
Oh, we are?
We are. We're on Facebook Live. And theoretically, if anybody was watching, if anybody, no one's really watching, but if anybody was really watching, they could call in with questions and talk to us. But this can also be posted, so later on people could review this. And Dr. Massie is a urologist, and you specialize in women's health. So why don't we just start right there? What are some of the things that you treat as a urologist who specializes in women's health?
Okay, well, so first I was trained as a urologist. I did all my training, got my urology degree, practiced urology for about 15 years, and then I went and took the certification to become a urogynecologist, because in my practice I was just doing mostly female things, and I mostly enjoyed the female issues that happen, the medical issues and the surgical issues. I also treat kidney stones, so I cover a lot of urological things. So some of the things that I see in my practice, I see a lot of incontinence, I see a lot of pelvic prolapse.
Now, incontinence in women or incontinence in both women and men?
Well, I started at women and men, but my practice kind of was geared more towards women. So that became my focus, and that became more of my interest, is dealing with voiding dysfunction in women.
Okay.
So, here and there I would get my partner sending me stuff, but they wanted me to see the female.
And how does incontinence in women in general differ from the type of common male incontinence? So is there a sort of different types of incontinence that are more unique to women that really are not?
Well, I think women, one, for instance, stress urinary incontinence, that's something that I think you see more in women. You may see it in men who have had radical prostatectomies, where they just kind of leak at very low pressures, or they leak with jumping and coughing and tennis, but these are things that predominantly occur in women. So I'm seeing stress urinary incontinence. I also see overactive bladder. Now,
you probably look right there. That's who we're really talking to.
That's
Facebook.
This Instagram.
Oh, there's Instagram.
Okay.
Cool.
Okay. All right.
Sri, I'll call you back later. But so stress urinary incontinence. That's where we were. That's what we were at. And so describe what that is. Who is that patient?
So stress urinary incontinence can affect any women. An example of stress incontinence is a woman would say, I leak urine, but specifically if I'm exercising, or I'm walking, or I throw up, or if I step off a curb, and then they notice a gush of urine.
Why does that happen?
Typically it happens because after women have children, that pelvic floor becomes a little bit damaged. I mean, we have a great tendency to heal, and the body recovers quickly after pregnancy, but that pelvic floor does take a huge hit. So stress urinary incontinence may happen because you've got those weak pelvic floor muscles. The urethra becomes kind of hypermobile. It kind of becomes kind of flappy, so to speak, and so we have to stabilize things.
So can you be more specific about what pregnancy does to the pelvic floor, how that affects it?
Well, I guess the main thing, you're for over a long period, over 9 months, you're carrying this growing person inside of you, and it's just sitting right there on that pelvic floor. That pelvic floor takes a huge hit. Also,
is it stretching the muscles out?
it's putting a lot of pressure and tension on those muscles. Yes. And
So if you're putting tension and pressure, why aren't they getting stronger?
well, because I guess you're not doing anything. I guess to kind of it's very difficult to. For instance, when you work your biceps, you're extending and you're flexing
Right.
and extending, but
And you get exhausted too.
Right.
You get to a
Right.
point of exhaustion.
But with that pelvis, that the baby's sitting on the pelvis, and although it's holding the baby, it's not really doing the exercises that we would recommend, or that you can really engage in when you're to help some of this incontinence or pelvic floor issues.
And so I'm just trying to understand the leakage issue. So how the urine escapes the bladder when
Right.
you cough or play tennis
Right.
or whatever.
So sometimes that the even the muscles that are kind of holding the bladder in place, the urethra, just that pelvic floor, they just become weakened.
Okay.
They're not destroyed, they're not ruined, and so what happens is when you do an activity that puts increased abdominal pressure, tennis, jumping, a little bit of urine is going to come out. Now it's not going to be. It may be a lot, but it's not going to be continuous flow. I mean that the bladder, the urethra can recover, but it's a sudden action that causes that leakage to spill out, and that obviously is very bothersome for women.
Sure,
Yeah.
sure. And those muscles can be strengthened. I believe they're called Kegel.
Yes, you can do Kegel's exercises to strengthen. We teach women how to do it in our clinic, and sometimes we even send women to physical therapy. I think physical therapists are really important, specifically pelvic floor therapists, who they teach these women how to use that pelvic floor to exactly which muscles to tighten, which to relax. So, and I think
Sounds like we need to do a show on that.
yeah, I mean it's
on teaching people
yeah.
these exercises.
Yes, I think it's because people don't want to just jump into surgery. That they don't want to say, oh yeah, surgery. I mean, you want to give them options of exercises.
When do you get to the point of having to do something surgical to correct stress incontinence?
Right. Well, a lot of women, they're very intelligent. We've already done these exercises on our own. So I make sure that, we say, have you tried these exercises? Do you feel that you've done them appropriately? Even kind of maybe go over it with the exercises with them. But I think at some point the woman's going to say, I've done that and I need to move on. The surgery for stress incontinence, for instance, is a mid-urethral sling. Now, there's several surgeries that can be performed. One thing that's done is the mid-urethral sling, and that is a sling that supports the urethra. Kind of think of it as a hammock that the urethra sits on. It just kind of gently sits on it. So when you put pressure on it, that sling offers counter pressure.
Is the sling some tissue that you take from the body, or is it something you get off the shelf?
Right. Well, you can use you can use tissue from your own body. We call that a fascial sling, or more commonly we use mesh. Now this, of course, people get very worried about mesh with all the bad press it's gotten, but this particular mid-urethral sling has actually been tested. It's been studied. There have been control studies. I mean, this has gone on for over 20 years, so we have good data, and there's very good studies out there, and it's been highly successful. And that still may bother women, so there's other techniques we can use to help with the incontinence.
So that's you see?
Sorry.
Oh, this is the best. No, this
This will be
people know is a real deal. Do you need to get that?
No, that's my sister. Okay.
All right. What else? So what other things do you see as a urogynecologist?
So we see, and there's several types of incontinence. So another thing may be overactive bladder. So women with overactive bladder will say, I gotta go, and I just don't make it to the bathroom in time. And sometimes I leak, sometimes I don't. And of course, that's a very bothersome feeling because they feel like they're tied to the bathroom. So that's another type of.
And what's a typical cause of that?
Well, there's certainly it's multifactorial. You can see it you can see it in all ages, but as you get older, you tend to see it more. So it could be due to estrogen hormonal status. Another thing that happens is, weight is a big cause of this overactive bladder. So we look at women who are heavier, and we try to counsel them on losing weight, because you do see improvement in your incontinence with weight loss. Women who have had previous pelvic floor surgeries, they can have their pelvic floor may be not very functional, and they may actually develop overactive bladder after they've had surgery. So there's a lot of different causes for overactive bladder.
What can you do for that?
Well,
obviously it depends on the cause.
It does depend on the cause. So we look at the simple things first, like what's your diet? What are you drinking? Because believe it or not, a lot of people drink things that they think, doesn't bother the bladder, but caffeine is a big no-no. Carbonated drinks, juices. Some people are on diets where they have to drink tons of water, and actually that may go against the, kind of counterintuitive to what you think. So we counsel on diet. We counseled on time voids, for instance, going to the bathroom at a certain time. We kind of, just as you were potty training your child, we kind of go back to some of those easy steps, really concentrate on going to the bathroom, getting up, leaving, timing yourself so that you're not just going to the bathroom all the time. We counsel women on their diet, making sure they're not eating too many things that have salts in them, which is bringing in a lot of fluid. Acidic things that may exacerbate the bladder, irritate the bladder. Next we go to, what are your treatment options? Medication is definitely an option, so we go over different medicines. And
what are some medicines for that?
Well, some of the medicines that are common medicines that you may have heard of are Vesicare and Mirabetriq.
What do they do?
They kind of help relax the bladder so that they're not causing the bladder to fire off so much.
Okay.
And it just depends. A lot of women have tried these medicines. They've seen their primary care doctors, and their primary doctors have already prescribed some of this stuff. So we kind of.
Do you ever do surgery for overactive bladder?
Yeah. So when the medications don't work, or we feel that we've come to just the end of all our treatment options, then we go to third line therapy, and that's where I think the urogynecologists really do a lot of stuff. So we can do Botox injections in the bladder. We can do nerve stimulation, tibial nerve stimulation, and we can do sacral neuromodulation. So those are the three main treatments.
You have to say those again for me. You can do Botox, which I get, and I think most women out there get, but they might not think of it in terms of the bladder. So that would relax the bladder muscles.
It does. Just kind of like it relaxes the face, wrinkles, it does the same thing.
And then the second one you said is what?
It's called tibial nerve stimulation. So there's
tibial nerve.
If you kind of think of it like acupuncture almost. When you go through acupuncture, they're putting needles in certain pressure points that may help your back pain and everything. Well, the tibial nerve kind of runs behind the ankle bone, and we can stimulate that nerve, which helps with this urge incontinence. Yeah.
Fascinating.
Yeah.
So, I'm a physiatrist, so I do EMG and nerve conduction studies, and we stimulate the tibial nerve all the time. So I'm just trying to think about, the tibial nerve in the foot, which is S123.
Correct.
And the bladder is S123.
Right.
So somehow you're stimulating the nerve, and there must be some sort of convergence.
Exactly. Yeah.
In the spinal cord.
Right.
And it's so do people wear stimulators around their tibial nerve, or how does that work?
That may be next line therapy, but they come in once a week for therapy for a 30-minute sit-down session, and it's super simple to do. There's absolutely no contraindications. I guess the biggest thing, if you have swelling and we can't really identify your ankle too well, but for the most part, anyone can tolerate this. And we stimulate the nerve that runs behind that bone.
That's fascinating. Yeah. When I was a medical student, I did a month of urology in my training, and the urologist I worked with, he specialized in urodynamics. So he was it was fascinating to me. But he examined everybody's feet. Oh. Everybody got a foot exam in this urologist's office, and he was looking for their strength in S123 and their ability to move their toes and abduct their toes as well, because those are your nerves.
Right.
It was just fascinating to me.
Right.
And now you're stimulating the nerves that go
Right.
to the feet in order to help an overactive bladder. What was the third one?
So the third one is called sacral neuromodulation, and it's a big word, but what we do is we stimulate directly the S3 nerve. So we're working right over the sacrum, and with the aid of fluoroscopy and with our landmarks, we can place this a tiny electrode into that kind of sits right by that S3 nerve, which is actually a big nerve, and that helps a lot with bladder control. And believe it or not, with fecal incontinence too. So subsequently, we also treat fecal incontinence. So when women come in,
I'm placing needles in that
Yeah.
foramen all the time, but
yeah,
I want to watch that actually.
Yeah,
that sounds interesting.
it can be. We do it in the office to test.
Oh, in the office.
Yes,
Okay.
we can test, or sometimes if people don't feel like being prodded in the office, we can do it in the operating room. So, but it's the great thing about it is you're not put to sleep. It's done under a local anesthetic. So
does that neuromodulation, does that thing stay in there?
It does. Once we get in the correct place, the lead is.
So this is like spinal cord stimulation.
Exactly.
Gotcha.
It's put underneath the skin so you don't see it, and then it's attached to a battery.
Okay.
And
Okay.
the battery lifespan is 5 to 10 years.
So here's a question. It says, what's the expected recovery time for robotics pelvic floor surgery?
Oh, okay. So robotic pelvic floor surgery is done for women who have pelvic prolapse, and it's not for everyone, but it really works well with a significant, moderate to severe prolapse. The recovery time is about 6 weeks. The first 2 weeks are kind of rough, but women are allowed to walk and move around. Some people go home the same day, some people go home the very next day. So they're not in the hospital very long. But 6 weeks until you're back in action, really.
And so robotic, what is it that you're doing robotically versus manually?
Okay,
and
so-
how do you decide whether you can use a robot or not?
Right. So the surgery, it's called a robotic sacrocolpopexy. It used to be done abdominally, where you'd actually make a large incision from the umbilicus to right above the pubic bone. But now we can use a device, this robotic instrument that allows us to work deep in the woman's pelvis with a tool that has that allows us to use all our 360 degrees of motion to work down in the pelvis. So it's just a way of doing a different type of surgery. I guess it's called a robot because the physician, the surgeon's not really sitting right at the patient's body side. We're at a remote in the room location, and we control this.
So you're at the
device.
beach while you do this?
Not at the beach, but right there in the room, and we can control the instrument.
Okay, so here's a question. It says, what is the difference between a urologist and a urogynecologist?
Well, a general urologist treats the kidneys, treats the ureter, the bladder, prostate, so anything like that. A urogynecologist is a person who's more trained mostly for the female pelvic health. So we're really not dealing with any men at all, and we're dealing with disorders of the pelvic floor.
Okay.
Yeah. So we don't necessarily do the oncology part. We don't necessarily do, although I do kidney stones because I've trained in urology. Some of the urogynecologists don't do kidney stones also.
So, more importantly, how do people get a hold of you? Urology Centers of Alabama,
Urology
right?
Centers. We're under the big umbrella of Urology Centers of Alabama, but we're Urology Centers of Alabama, the Women's Center.
Okay.
Yeah.
And is there a website or anything like that?
Well, it's,
Probably.
yeah, UCA is. I think there is. We have a great website. I automatically just look to it on the computer. I don't even think about it. But
Super.
Urology Centers of Alabama.
Okay.
And it pulls up the Women's Center too.
Well, I appreciate you taking
Well,
this
thank
time,
you.
and if you think of things you want to talk about with me on Facebook Live, you want to
Okay.
share or something like that, then that would be great. And this wasn't too hard, was it?
I guess.
I mean, considering we had phone calls,
Yeah.
I appreciate it. All right. So I'm going to leave this running, actually.
Oh, really?
Yeah,
Okay.
because you might say something that I want on the show, so I'm not gonna stop yet. But
Oh, okay.
we're done.
Oh, okay. Okay. All right.
I find that when I keep it running, then that's when more information starts pouring out. So just in case, I'm just gonna keep it running just in case more information starts pouring out. All right. We really are done though.
Okay, good. I was like, I don't have to sit here.
No, you don't have to sit there at all.
Okay.
I'm going to hit finish.